So this lecture is on autoimmunity and the diseases specifically. So what the diseases entail clinically and how we help to diagnose them in the laboratory. The autoimmune disease process, any condition where the immune system is attacking your own body tissues. Any of those will be classified as an autoimmune disease. So basically you've got damage in one or more organs, tissues that comes specifically from some cell that is autoreactive. So a B cell that's producing an antibody against an antigen expressed on those tissues, or it could be also a T cell that expresses T cell receptors specific for antigens that are expressed on those tissues. Autoimmune disease processes, they're actually pretty rare. Only between 5 and 7% of the population actually has a can have an autoimmune disorder, and basically, as you know, the general definition is where there's some kind of breakdown, some kind of loss in self-tolerance. So the immune system, you are not recognizing self in one or more antigens expressed in your own body. So that's basically what's going on in a very general sense. But obviously, each autoimmune disease is different from one another in how they're expressed. The way that they are the same is how they occurred. So in order to understand that, we have to talk about central tolerance and peripheral tolerance. This self-tolerance, right? Being able to recognize what's yours and what's not yours, okay? And so tolerance is built up in several areas as the immune system develops. It begins with central tolerance, which is when lymphocytes are detected that react to self-antigens. Those should be destroyed. So this occurs during maturation. The white cells mature, and as they start to express either their B cell receptor, which is immunoglobulin, in the B cells, or T cell receptors, which is their receptors. Those receptors, if they are noted to respond to self-antigens, those would be destroyed in either the bone marrow or the thymus, respectively, right? But B cells in the bone marrow, T cells in the thymus. That requires several things to happen. The antigens have to be there, blah, 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 all that stuff. You went through that in immunology. However, central tolerance, being able to get rid of those white cells that are reacting as they mature, they're reacting to self-antigen, that's called central tolerance, and that's the first step in reducing the rate of autoimmune disease. There is, however, peripheral tolerance, and in peripheral tolerance you have, this occurs now the cell has matured enough, it's still relatively immature, but it's matured enough to leave the marrow or the thymus, respectively. And then they start moving through the lymphatics, right? They go from lymph node to lymph node, through the spleen, through the tissues and all that stuff. And as they go there, remember, these are cells that are supposed to change their sensitivity, right? They're supposed to be able to modify the receptors that they express, the goal being to become more specific for the offending antigen. However, unfortunately, you may sometimes have those cells that have left now, right? They've been deemed to be okay to leave the thymus or the bone marrow, and they could get triggered. They could actually change to become more specific for a self-antigen instead of that offending foreign antigen. And so peripheral tolerance is what occurs on outside the thymus and the bone marrow to help prevent that part of autoimmune from developing. So we want to make sure that we don't end up with either receptors that become more specific for self-antigen or an overreaction of T cells, B cells that are specific even for an offending antigen, because if they overreact to it, then that could also lead to a problem. And so in order to do that, we have a variety of other immune cells that have to take place. So you have, as you know, in your peripheral bloodstream, you have Th1 cells and Th2 cells. Those two can work together. The balance between the Th1 and the Th2 cells helps to regulate the type of immune response that you're going to have. Are you going to have an antibody response? Or are you going to have a cellular response? We know that that's important. They also seem to help mediate autoimmunity. So Th1 especially, the Th1 cells seem to be the ones that are primarily in charge of mediating autoimmune disease, preventing, in this case, the majority of them will be preventing B cells from becoming overstimulated so that the B cells don't start producing antibodies to just any old thing, okay? But we also have T regulatory cells, or Tregs, and these also will play a central role in maintaining the balance between self and non-self. And that's because the Tregs, their main job is to keep any immune reaction from continuing on ad nauseum. There has to be an end to an immune response. And the Tregs, they're very important in that process. Then we also have MHC, which is the, remember, you have a T cell receptor and you have your B cell receptor, which happens to be immunoglobulin. The MHC will really be the key in any specified or any adaptive immune response, because the antigen has to be released, has to be expressed, and presented in the context of MHC. So MHC will be able to influence which antigens are expressed or not, because not every antigen can be held by the MHC that you express, right? You have a limited number of MHC molecule types that are expressed on your white cells. Well, in those types, you have a limited number of antigens that they can hold. There is just a limit. It's the way it is. And so if you are unable to hold antigens that belong to self, then that's good. You're less likely to have autoimmune disease. There are certain MHC types, unfortunately, that are more closely associated with autoimmune, and that's because of they are able to hold those antigen sequences. So if there's a close fit of an antigen of a foreign antigen that also happens to have a relationship or some kind of similarity with self-antigen, again, here's where autoimmune disease can become a problem. So as we have gone through and they've studied autoimmune diseases, they have found that there are certain MHC types, meaning certain HLA sequences, HLA types, that are much more common, much more associated, I should say, with certain autoimmune disease processes. There are also some other mechanisms that will influence whether or not, well, just to sort of tie these together in this little, you could see this little Venn diagram. My husband loves Venn diagrams. You can see there's going to be components that come together in the development of autoimmune disease. The genes that are involved would be your MHC, your HLA genes, right? So those are the specific types of MHC that you express. Then we have immune regulation. Do you have a depletion of your T regulatory cells? Do you have an overabundance of Th1 cells or a reduction in Th1 cells? That's going to play a part. And then the environment also. Are you exposed to antigens that happen to, pardon me, mimic or share a relationship with your own self antigens? Is there some kind of relationship there? When those three things come together, you end up with this. It's still a small amount. It's still a small chance of the relative whole, but you do have a high, a greater affinity for autoimmune disease. There are also some situations that occur that kind of are separate from the randomness, right? So there are situations where genes that, or antigens, I should say, which are normally sequestered, end up being released into the external matrix, right? They come in close contact with your immune system. So what are some examples of that? So for example, one of the good ones is myelin basic protein. Myelin basic protein is obviously supposed to be part of the myelin, which is the sheath that covers your nerves, and that's not usually, that shouldn't come in contact really with the external or the peripheral blood, right? Shouldn't reach your peripheral immunity. Neither should things like, let's say, some neonatal or some fetal antigens, or sperm, for example. They all contain antigens which normally don't come in contact with your peripheral blood. In the cases where they do, your immune system was not trained against them because when they were being formed, and so they would much more easily be seen as foreign. Okay, and so you can end up developing immune responses against them. We also have molecular mimicry, which we've talked about before. Any viral or bacterial antigen, they are able to mimic self-antigens. Now that can be an advantage to the virus or to the bacteria, because then that organism is not seen as foreign, so your immune response against them is weaker and they have a better chance of surviving. Unfortunately, if they are close, you also have a better chance of developing some kind of reactive immune response. And then the reality of the way the immune cells work is also an issue. Polyclonal B cell activation, where this would be a B cell defect, right? So having multiple B cells being activated at the same time. When B cells are activated, right, they're supposed to go through hyper mutation, right, of their genes, produce more and more specific antibodies. When you have, but that's regulated by Th1 cells. So only one particular clone, a single clone of B cells, should be activated. If you get multiple clones activated, you're much more likely to produce like varied antibodies that could potentially react with self-antigen. Okay, you have less control. So we really don't want polyclonal B cell activation. We want a single clone to be activated, not multiple clones. So the first and the classic autoimmune disease that we go through is systemic lupus erythematosus, or lupus, or SLE. We usually refer to it as SLE out of the lab. The media, I guess, calls it lupus. Okay, this is the prototypical autoimmune disease. Okay, it is a chronic systemic inflammatory disease where the patient goes through, they actually have sort of exacerbations and remissions is what they're called. So where their immune system goes crazy attacking their tissues, and then their immune system relaxes and dies down. Okay, and the patient goes through, so fits and starts is basically what happens to these patients. It generally affects between 15 to 50 individuals out of 100,000 in the US, and that's a pretty wide range, and the reason for it is the difficulty in diagnosing it. Okay, just to give you an example, I had a friend, she's like a 42-year-old, you know, so middle-aged firefighter that I know, thought he had lupus. I'm like, you don't have lupus. He thought, but he swore he had lupus. Some doctor, he had a low pos ANA, and the doctor says you have lupus. That's not the definition of lupus. It's a lot more than that. And we know, for example, that there's a lot more women that have lupus than men. So I go with the stats and I go, I think maybe that your symptoms are caused by your drinking too much and not maybe so much your lupus. That's me. Okay. But it is very difficult to come to a final diagnosis, and it really should require somebody who's a specialist in this. You really should see an immunologist. You shouldn't see just, you really need to see these allergy guys, these guys that do this. If you're just getting this from your, primary care, maybe not as experienced in this. I'm not saying that he or she wouldn't know what they're doing, but it really is difficult because there's so many, the lab results are not necessarily 100% clear all of the time. So hence the range, okay? You get, for the patient, the clinical symptoms, there's a wide array of manifestations. Again, another reason why you have this issue. There are a couple that are sort of prototypical. So if you see them, they're very, very strong evidence, and that would be the butterfly rash that occurs usually on their face, over their nose and cheeks, and photosensitivity. That's pardon. Photosensitivity is also prototypical sign. The other things are a lot less clear, so they might experience oral ulcers, they might experience arthritis, pleuritis, pericarditis, kidney problems, including they could have things all the way as serious as seizures, so neurological issues. They could have mood changes, psychoses, changes of their behaviors, and they can also have blood cell abnormalities. The range of manifestations is wide, and not every single exacerbation will look exactly the same for the patient who has it. For us in the lab, what is it characterized by? In systemic lupus, what we see is that the patient is producing antibodies to components of the cell nucleus. So a lot of people think of it as DNA. It's not really just DNA. You're not producing an antibody against DNA by itself. You're producing an antibody against the components, so DNA plus histone. So the complexes that are formed in the nucleus. So obviously this isn't good because you have this in most of the cells in your body. And so that's why so many different tissues can be affected. But primarily, we don't see this in middle-aged firefighters. We usually see this in disease of young women. So we see this starting to develop in women in their, early adulthood is when we start, teenage to early adulthood, we start to see this emerge. Again, not necessarily aware of the trigger for it. So the patient might see the symptoms. It could take a while for them to get a diagnosis, but the range of dates, you can see this develop very early on, even in infancy, and we can see this also develop older, but the peak occurrences start with the age of 15, and we see diagnoses from 15 all the way through 40. So you see usually the peak occurrences are in that early adulthood. And females much more likely to be affected than men. It's almost a 10-to-1 ratio. So Again, I'm still arguing with my firefighter friend. There are also differences in the races. Uh, Blacks are much more likely to be affected than whites. And actually, it might be that Hispanics and Asians and Native Americans might also be more affected. The jury's still out on those numbers. There can be a familial aggregation, um, much more likely to be related to an HLA type issue than actual, like, sort of, you're not inheriting the disease, you're inheriting the tendency for it, if that makes sense, okay? It is still a relatively uncommon disease, however, okay? So most cases, it's still a sporadic finding. It's not like you're going to trace it through somebody's family tree really easily. Again, the diagnosis can be very difficult, and a lot of that has to do with what the patient is experiencing. The doctors find themselves chasing the clinical symptoms instead of looking for the cause frequently. And so the cause, they kind of stumble upon it maybe later on. The gold standard for diagnosis requires a rheumatologist. You do need to go to a rheumatologist who's our immunological doctors in order to find that. And they have a classification scheme that requires, they have these 11 criteria, and you have to find 4 of them in order to really diagnose the patient. There's some controversy. Could that miss some early diseases or some mild cases? Probably, but that's still considered it's the gold standard. That's how that happens, right? This is how we always did it. Keep doing it this way until we find a better way to do it. Since this is still a severely misunderstood disease as far as the triggering things, then we definitely have some work to go as far as gold standards go. Even with this, we do find that there's probably a rate of under reporting, and that probably has to do with those periods of remission and the differences between the relapses. The patient might not recognize that what they are experiencing this time is the same as what they experienced that last time, which might have been 2 or 5 years ago, if they're lucky. Okay, they may not see a correlation between the two. And so if your patient can't see the correlation, why would a doctor who's not experiencing it see any kind of correlation unless they're really, really looking for it? Okay. Unfortunately, there is some accusations, like for example by me, of overdiagnosis, and that's because there are some doctors who do use just a simple blood test to try and then tell their patients that they're diagnosed. But the reality is a lot of these blood tests can be positive in the healthy population. In particular, a very low positive titer can be perfectly normal in the healthy population. So it's a misunderstanding of what the lab results mean that can cause the discrepancies in diagnosis for the doctors. And that's part of our job. We have to educate the doctors. There are some things, however, that do help in the findings. So some of the immunologic findings that we have that help us to come to a diagnosis, if not arrive at a diagnosis, include probably the first one, which is not easily found, but if it is found, it is highly suggestive, like very, very suggestive, and that's called the LE cell. And that's shown here, down here. And what you see is this was first seen or first discovered by Malcolm Hargraves in 1948. So we've known about this for a while. And you can see that the neutrophil has engulfed the antibody, what that is inside that we now know. It looks like it might be some kind of maybe a lymphocyte or something, but what it actually is the nucleus of another neutrophil that has become coated with antibody, which will change its shape, obviously. Okay, so now this does not happen all that commonly, It actually mainly occurs in vitro. So this neutrophil actually probably engulfed that nucleus while it was in the tube that they made the smear from. Okay, so when in vitro, those cells that are damaged, which they are because of the antibodies, they'll release nuclear material, and a nucleus, a seg that's still functioning inside the tube might engulf that. That might happen. And that's called an LE cell. So these aren't something, if you did like a stick preparation, you went and you just took literally a drop from a patient's finger and you created a smear directly, you're probably not going to see an LE cell. But if you make a preparation from a tube that's been in the lab for an hour or two, you might see this cell. And that's actually pretty highly suggestive of lupus. Okay, and that was in 1948. It was 9 years later that the first anti-DNA antibody was discovered, and that became associated with SLE. Okay. Now, unfortunately, we can't say that there's any. This is the problem with SLE. You see all the lists of these, antibodies and altered things that we can find, but there's actually more than 25 autoantibodies associated with lupus. Okay, and we'll look at them on the next slide, but they're the more common ones anyway, not all 25, but there are more than 25. So you can see that it can become very confusing if you're not well versed in how to interpret these results. Okay. All of these antibodies, 25 of them, that really is a reflection of the overall dysregulation of the immune system of the patient. Okay, so they tend to have T and B cells which have uncontrolled autoreactivity. That's the major problem. Without control on these cells, they produce all these antibodies, and they're not stopped in what they're doing. And that probably relates to the T regulatory cells, a deficiency in those cells. Okay, what they have found through studies is that the T regulatory cells that are present in these patients, they seem much more sensitive to apoptosis than in a healthy patient. So they're much more likely to be triggered to self-destruct, apoptosis, die on their own than an otherwise healthy patient. So that's one of the problems. Without proper T regulatory cells, we end up with many more autoreactive T and B cells. In addition, there's an altered Fc receptor that's produced out of the antibody that and that receptor is on the IgG, and that keeps them from being switched off. So normally that Fc receptor has a limit on it, so it can't just continue to react constantly, the B cells. So, but the Fc receptor on this particular antibody is altered, and the B cells are able to produce antibody for a much longer period of time than a proper Fc receptor would allow. Okay, and then also these cells have abnormal rates of apoptosis. So what normally happens in apoptosis is that the cell it implodes in a sense. It is killed off, but still maintained within its own skin, so that the contents within, and if you think of it as apoptosis is not just a mechanism of normal cell death, which it is, but it's also something that's triggered to stop transformed cells and or virally infected cells from spreading. And so if we contain those cells that are dying in themselves, they just shrink into themselves, then the contents, which are considered offensive inside, they're not released into the rest of the environment where they could potentially harm other cells. But unfortunately, the process of apoptosis in patients who have SLE, not in all cells, but in the affected cell types, that process has been changed. And instead of maintaining all the junk inside itself, keeping, nice clean death, nice and tidy, some of the cellular constituents are released, which would only trigger the immune response against those even further. Okay, so again, more and more antibodies are stimulated. The things that seem to be released at a higher level in these cells are both DNA and the also some of the RNA structures. Then we also have sort of overactive or overreactive T1 and T2 triggers, in that when they are stimulated, their production of cytokines is much higher than another patient's production would be. So maybe an immune response that would normally remain localized ends up being systemic, hence the systemic part of the disease. Okay. And then finally, there are definite defects in immune complex clearance. There are defects in every part of the immune system in a patient who has SLE. Okay. Yes, there are lots of different things going on with these patients. And as the disease progresses, these just become even more and more accentuated, worsening the disease. One of the reasons why they have trouble removing those immune complexes is their expression of complement receptors, and the receptors for that FC portion of the immunoglobulin, those are all missing. They start to change their complement receptors on those phagocytic cells. So it's almost like you have a built-in thwarting of the immune system in these patients. Now, while most SLE is sort of genetically run, we're not sure of the trigger, but it is related to MHC type or HLA type, I should say. There are some cases of drug-induced SLE, and this is where the patient has some of the symptoms, not all of them, but some of the symptoms that are also associated with SLE, but that those symptoms disappear once they stop taking that drug. Okay, so that's good. So this is a temporary thing. And the drugs that are implicated, so if your patient is on one of these drugs, then the first thing you have to do is discontinue the drug and see if the symptoms disappear, which might take some time. Okay, so the most common drugs implicated are procanamide, hydralazine, and chlorpromazine, as well as isoniazid, quinidine, and the anticonvulsants, in particular methyl-dopa. And also there's some evidence that oral contraceptives might also lead to some of these symptoms. So the first thing to do if you suspect this in your patient, if they are in any of those drugs, the first thing to do is stop those drugs. If you stop those drugs and the symptoms disappear, then you know that you have drug-induced SLE, and you shouldn't use those drugs going forward, whichever ones you were using. Now these are the antibodies. This is a list of the antibodies that are related, just some of them. You can see there's a pretty good list here. So you've got the first test that you're going to run for this is a screening test, and that's called the anti-nuclear antibody. And it can test for a wide range of antibodies that are directed against nuclear components, but it doesn't get specific. So if your anti-nuclear antibody is negative, well, then none of these are going to be, or most of them won't be an issue. If your anti-nuclear antibody is positive, then we start to go to some of these. When we look at the anti-nuclear antibody, and you'll see some of these later, we report not just positive and negative, not just a titer, but we also report a pattern, okay? And the pattern here, and this is what they're talking about here with immunofluorescent pattern, the pattern that we see on the anti-nuclear antibody is associated with certain types of autoantibodies. Okay, so for example, if I see a homogeneous pattern on my ANA, it is more likely to be an antihistamine than it is to be an anti-Smith. Okay, anti-SM is anti-Smith. So you can see that the anti-Smith is associated with a speckled pattern. So that's the pattern that we're associating with. This is the immunofluorescent pattern on the ANA. Okay, so this would have been done before you found this. And you can see that the disease association, yes, they're associated with SLE, but unfortunately, not just SLE. So there are some other diseases. This is why you really do need that the rheumatologist to help you out with this. The other diseases that could be either a comorbidity, or it could be, you're misdiagnosing it. It's the wrong one. You have mixed connective tissue diseases. You have Sjögren's syndrome. You have systemic sclerosis. You have scleroderma. You have poliomyelitis. You have RA. And those aren't even here. Those are with the other 25, right? So you're probably going to be running on your patient more than one of these in order to hone in your diagnosis. When your doctor orders all of them, they're not being a brat. They really are trying to fine-tune their diagnosis to see exactly what parts of the nucleus are offensive to their patient. Okay? By far, the one that they probably are going to look for first is the anti-double-stranded DNA. That is highly associated with SLE, okay? And it's not as closely associated with some of the other ones, so it really does tie in very closely with SLE. The other ones, however, are helpful because you could have comorbidities, and so you'll frequently get these other antibodies ordered. So from this chart, definitely know what we're talking about here, what the name of the autoantibody is, what drug it is suspected with, and what ANA pattern it's also suspected with. Okay, so little chart for you, easier to study from. So this is the ANA. This is where you're going to start. So it's a fluorescent anti-nuclear antibody, or sometimes in some labs they call it FANA, F-A-N-A, for fluorescent. Most of the labs I worked, it's still ANA. This is actually a screening test, as I said. It's very sensitive, so it's going to find if your patient is reacting against nuclear constituents, but it's not very specific. That's important, okay? So it is widely used. You'll do a lot of these in serology, but it's not diagnostic. You can't use this. This is not the end of your diagnosis, okay? It just allows you to rule out. And it's also, they've automated it, which is lovely. They've automated the test, the screen. They have not automated the titer yet, so you still have to do the titer. So this will be, the ANA will be positive in about 95% of patients with lupus. So that's pretty sensitive. That's not 100% though. Note that, okay? Remember that the patient could be going through remission as well, so that always becomes an issue. So the test itself, you have a slide that has a cell attached to it, and there's depending on the manufacturer, they might use either a mouse kidney cell, or they'll use a HeLa cell, or actually a HEP2 cell, which is a human epithelial cell, and those are fixed to the slide. And they're allowed to react with your patient's serum. So if there's any antibodies in your patient's serum, they'll attach to the nucleus of these cells. You wash off the excess. This is you know exactly how this works, what this technique is. And then you add conjugate that has anti-human IgG that happens to have a fluorescent tag. You could do it with an enzyme as well. Attach to it, let that react for a while, rinse off the excess, and you will end up reading under the microscope looking for, in most cases, fluorescence is what we're looking for. The automated versions use an enzyme and they look for enzymes, okay? About 2% of healthy individuals and up to 75% of elderly individuals will test positive without any signs of SLE, okay? So, and remember, there's still up to that 5% of patients who actually have SLE who will test negative. So we know that while it is very sensitive, it's not an absolute test, okay? We do get positives, kind of a lot of positives, and that's why the titer is important. Some hospitals have decided that instead of reporting those low titers, they're going to raise the bar for negative, okay? That's going to change your sensitivity a little bit because you're going to miss some of those SLE patients who might be in remission, but you're going to stop triggering positive results for so many patients who don't have SLE. So, but the reality is it's not an absolute test, okay? So you do a screen, usually, and every hospital is different on the protocols that they use. The manufacturers usually suggest that you start at a 1:40 or a 1:80 dilution in order to test for this. Again, some hospitals have raised that to 1:160 so that we avoid those low titer positives. And that's because patients who are above 65, we get a lot of low positives, okay? And some hospitals, I know a hospital that they actually do, anybody who is over 65, the titer starts at 1:160. So they do everybody else, the younger people. Remember, it usually affects, it's usually diagnosed in younger people. So they usually start at a 1:40, but if the patient is over 65, they switch it to 1:160, okay? And then you'll get either you'll either have fluorescence or you're negative, so you report the test as positive or negative, and then you report the titer as well. You know, you do a doubling dilution from whatever your start point is, and you report the titer, the last titer that's positive, okay? And then you also report the pattern. And we have 4 patterns shown here. You can see a speckled pattern here where it's very difficult just to look at this picture because you can't make it closer to you like you can on a real microscope. So you would be looking at the microscope and you can see that this is an uneven pattern across the nucleus, and the speckled pattern usually doesn't include the nucleoli. You can see that here. The homogeneous pattern, obviously, very smooth, but you can get any nuclear component, and you can see that here in the centromere pattern, where just the centromeres of the chromosomes are shown. And it would be a lot easier to see this if we had them lined up, because that's always easier to see when they're lined up. And then you have the nucleolar pattern where just the nucleolus is lighting up. We also have things like the rim pattern where just the nuclear membrane is lighting up. We can do a spindle pattern that you would only see in those phases that include the spindle. So you would only see that in phases with like metaphase, anaphase, those places. So again, you have to move around and you have to look at all the cells. What you're looking for, you have to look at those mitotic figures, and you can see here the mitotic figures in some of these phases. Look at here is an anaphase, and you've got those here. But you have to look for those to make sure that you don't have 2 different patterns in the same patient. So what did I say? I said spindle, centromere, centriole. Centriole is another one, right? So you would only see that when the spindles are present also. Rim, those are all things. You can also have overlapping patterns. So maybe I have a homogeneous pattern until, I don't know, 1 to 160, but I have a nucleolar pattern that goes all the way out to 1 to 1280. That's a possibility. Okay, so you have to watch that. You have to read everything to make sure that you don't have another pattern underneath the stronger pattern. Okay, and those patterns help to decide what follow-up tests should be considered. Okay, now the antibodies that the broad range of antibodies that you're really looking at here include the antibodies that I have listed here, the double-stranded DNA antibodies. Those are the most specific ones for SLE. So they're mainly seen only in SLE, but not in all cases of SLE. So we don't have a lot of other diseases that double-stranded DNA are found in, but only about 40 to 70% of lupus patients have them. So while they are considered diagnostic, they may be missing from your patient. And just a point there, they're only diagnostic if they are found in combination with low levels of C3. Okay? And again, you usually get that homogeneous pattern with the double-stranded DNA antibodies. One of the tests that the board still asks about is, it's a little bit of a different test for the double-stranded DNA antibody, and it uses Cirithrida luciliae. So Cirithrida, Cirthidia, luciliae, Lucillia. This is a hemoflagellate, and it has a circular double-stranded DNA in its kinetoplast. Okay, and so you let your patient's serum react with that organism bound to a cell, to a slide, and again, fluorescent stain it. And what you would see, since the double-stranded DNA is confined to the kinetoplast, the fluorescence would be also confined to the kinetoplast. And that's the gold standard for double-stranded DNA. Okay, so that's why it still comes up, because it is still considered the gold standard. But they have actually automated this test, the dsDNA. They have automated that, so we'll see how much longer we keep that. The antihistone antibody, this is the second major antibody found in lupus. Remember what histone is? That's the nucleoprotein, major constituent of the nucleus, and it helps to maintain the sort of the organization of the chromatin. And so the antibody against it is very, very common in lupus. About 70% of lupus patients have an antihistone antibody. Unfortunately, it's not only found in lupus. It's also found in RA. It's found in biliary cirrhosis. So we can't just rely on the antihistone. The anti-DNP, or deoxyribonucleoprotein, which is a complex of DNA and histone, so it's the other two together. Usually there's actually a slide latex particle test that you can do for the anti-DNP. Pretty simple one. That also, again, you're kind of combining the rates of the dsDNA and the antihistone for that one. But it's if you do what some labs do is they do an anti-DNP as a screen, and then they separate it into double-stranded or antihistone. Anti-SM or anti-Smith, depending on the age of your doctor, they might still call it anti-Smith. First described out of a patient named Smith, so hence the name. Okay, these are actually directed against these small nuclear proteins that are associated with particular types of RNA, uridine-rich RNA. Okay, so these are very specific in what they're directed against. And they are also specific for lupus, because they're usually not found in a lot of other autoimmune diseases. Unfortunately, they're not found in a majority of the cases of lupus. They're only found in about 7 to 25% of lupus cases. But again, if you find it, it is highly suggestive of a lupus diagnosis. And this one, the Smith, much more likely to be a speckled pattern on the ANA. Then we have the anti-SSA Rho or the so sometimes it's anti-Rho or sometimes it's anti-SSA. They're the same thing. And the same thing on the other side is sometimes it's anti-La. So when it was anti-Rho and anti-La at first, now it's anti-SSA and anti-SSB. So depending on the age of your doctor, they might refer to it as one or the other. But these are RNA complexes that are sometimes they're found in the nucleus, and they're complex to one of two different proteins, A and B. Okay, and these are the two antibodies that are associated with the photosensitivity manifestations. So if your patient expresses either of these antibodies, they probably experience photosensitivity at some point, and they're also highly prevalent with other autoimmune diseases, including things like scleroderma and Sjögren's syndrome. The anti-Rho or the anti-SSA, this is actually an antibody. It actually directs against a cell surface antigen that's also present on neutrophils. So the antigen is present not just in the nucleus, but also on neutrophil surfaces. And so it can end up causing mild neutropenia in your patient. And for these two, you must use, remember I said the ANA, you could use mouse kidney or HEP2 cells. The mouse kidney would not be able to detect the Rho or the La, okay? You have to use the HEP2 cells in order to detect those on the screen. And that's because the antigen doesn't exist in mice, okay? Then we have the anti-mRNP, which is a ribonucleoprotein. What it is a protein that's complexed to a particular type of nuclear RNA called U1mRNP. That's the protein complex. Okay, it is a uridine-rich RNA, and it is found, this antibody is found in anywhere between 20 and 40% of lupus patients. But again, it's not specific to lupus. It's also found in mixed connective tissue disease, systemic sclerosis, and Sjögren's syndrome. It's also found in other diseases as well. And then finally, the anti-fibrillin. This is a dense component of the nucleolus, pardon me, which gives it a clumpy nucleolar pattern, and is while it is found in lupus, it's actually more common in systemic sclerosis. So we can find it in lupus, but it's actually much more likely to be found in systemic sclerosis. Some of the other testing that might be done for your patient, this is actually just different techniques that might be used to do the same thing. So you saw that there's a lot of tests. Pardon me. There's a lot of tests that have to be done to diagnose our patient. And while quite a few of them have been automated, making it a lot easier, there are still some older or old-fashioned techniques that are out there, and they're still on the board, so I'm going to talk to you about them. Okay, immunodiffusion is still out there. It is not really used as much for this anymore as we automate, but is actually still used for some viral testing and things like that. Like when we don't know what virus patient has and we want to test a whole bunch at once, we can do that. We can customize our panels for the patient. So immunodiffusion allows us to identify immunologic specificity. And the technique that we use is called Australani double diffusion. And this allows you to detect antibodies against several small proteins, or in the case of antibody, you can use lots of different nuclear riboproteins or some kind of, a nuclear antigen. And that allows you to put them in different wells and then see where our identity is. So if you look at the way that it would occur, you have outer wells here that are dug into agar. It's a superfine agar. And then you have a center well that's going to contain our patient sample, the antibody. Okay. Now, one of the wells has to have a control. That's a rule, right? We know how that works. And then you can see the antigen 1, 2, 3. What do you want to put in there? Do you want to put anti-Smith, or well, actually, you'd put the Smith antigen? Do you want to put nuclear RNP? What do you want to put in there? Rho, La, go on down the line. So you put in the antigens that you suspect to trigger your patient, and then you put your patient's specimen that contains the antibodies in the center and allow those time to diffuse through that superfine agar. And then we start to look for precipitates that occur between the wells. And there are patterns that are associated with either identity or non-identity. And they're shown here. You have what are called an intersect, a spur, or an arc. Okay, and you can see them here. And this is just a blow up sort of what these three little pie things here look like. So you have, again, this is an arc, an intersect, and a spur. Okay, so in the arc, we know that this is a sign of identity for that particular specimen. Okay, if it's an crisscross, right? So if it's an intersect, sorry, that means non-identity, and a spur refers to partial identity. Okay, so and what they're saying is that the specimen, the antibody shows identity with, in this case, they're using color, so the red. So when you have the red here, it's reacting with this particular antigen, but not with the green, is what they're trying to show in this cartoon. Okay. So the Autoimmunity technique is not gone because it allows labs to customize, make their own antigen extracts if necessary. It's very easy to set up. Okay. However, as we automate these things, obviously automation is much easier than this because automation is done in just a few minutes, whereas this, you have to allow it to sit overnight. Okay, and you have to make sure your agar is perfectly produced and that everything is perfectly flat and that everything's allowed the right amount of time to separate and move through that agar. So the benefit of the Autoimmunity isn't so much increased sensitivity, because obviously allowing the antibodies to move through doesn't necessarily, it's not greatly sensitive. However, it is highly specific. So you can differentiate between those two antibodies very, very well using this particular technique. Immunoblotting is another mechanism that we can use. We can separate out antigens by means of, using polyacrylamide gel electrophoresis, and then transfer those antigens to a nitrocellulose sheet. And then the sheet becomes your test surface, right? Incubate that sheet with your patient's serum. And antibodies will attach to the antigen, which is, of course, fixed to the sheet. And then you add whatever your conjugate or your viewing molecule is, and you'll be able to visualize the bands. Okay, it's a little cumbersome, but it's certainly shorter than Autoimmunity, certainly. And then we have EIA, or enzyme immunoassay. It comes into wider and wider use for detecting antibodies, and this is when you have it in an EIA platform, you can automate it. It's pretty easy to automate. And those ones that have been automated include double-stranded DNA, histone, antihistone, anti-Rho, and anti-La, which is the SSA and the SSB. And it's particularly good for the SSA and the SSB. Remember, those are very small. They're very hard to find on those cells. Okay. EIA will be quantitative, and it is less subjective, right? So if you're having a machine read it, I don't have to do it. And the same thing too, if I just have to read yellow or blue, it's easy, which an EIA would give me. That's a lot easier to interpret as opposed to fluorescent staining, differentiating that from background fluorescence. And then we have one last thing I'm going to throw in here are the antiphospholipid antibodies. I'm throwing this kind of in general because kind of like the ANA is a screen for anti-nuclear testing. Antiphospholipid antibodies, this is also a heterogeneous group of antibodies and that can bind to phospholipids alone or phospholipids that have been complexed to proteins. So those ones, since you have phospholipid bilayers everywhere, it can affect any organ in the body, and it is associated in particular with things like deep vein or arterial thrombosis. It's associated with morbidity in pregnancy, and we have found antiphospholipid antibodies in about 60% of lupus patients, as well as several other autoimmune diseases. These antibodies are also a problem in other parts of the lab. If you express antiphospholipid antibodies, you'll get, for example, a false positive for syphilis, your RPRV, false positive. So these are some of the things that you should be aware of, okay? Because I saw that specific question on a board test. Okay, what can cause a false positive with syphilis? Antiphospholipid antibodies. The lupus anticoagulant is another, it actually is the first one that was discovered. That actually is a type of antiphospholipid antibody. And again, how does it affect the rest of the lab? It is actually, it's called lupus anticoagulant for a reason. Even though it's an antiphospholipid antibody, it actually interferes with coagulation. And so it'll cause, if your patient expresses this, it'll prolong their PT-PTT, which is part of what causes the patient to have a risk of clotting, including spontaneous abortion. So their platelet function is likely affected because of that. Now, rheumatoid arthritis is another autoimmune disorder. It's just painful, horrific pain that these poor patients undergo. I had a patient, one of my favorite patients I ever had. She was a sweet old woman, completely immobilized by rheumatoid arthritis and had been in the hospital for years. And that's because at one point, nursing homes wouldn't take you if you're on warfarin, and she had to be on warfarin. Coumadin in order to prevent clots. This disease affects between 0.5 and 1% of adults in the developed world. So that you see, it's a very, very small amount of people. However, the disease itself is devastating. What's targeted here are basically your joints, the joint linings. Unlike, everybody has wear and tear to their joints, right? Living does that. Normal osteoarthritis, that's just normal wear and tear, right? So you develop that as you get my age and better, right? Up into your 50s and 60s and 70s, it increases. But rheumatoid arthritis is different. This isn't just wear and tear. You're actually producing an antibody directed against the lining of your joints that can cause really painful swelling. It can actually lead to bone erosion and joint deformity. And you can see in this picture how the patient's joints have been so affected, that the bones have moved out of their normal positions, and their hands frequently, or whatever joint is affected, becomes sort of frozen out of, out of its normal position there. So that's kind of what you see with RA. It can sometimes affect other organs of the body, like the skin, eyes, the lungs, heart, and vasculature. And that's because some of those antigens that the antibodies are directed against are actually connective tissue antigens, which of course connective tissue is found everywhere in the body. But the primary target in this is still the joints. Again, there is a genetic risk for this, but it's not necessarily like you're passing down the direct disease. It's more closely associated with certain HLA types, in particular HLA-DR4. That seems to have a very high affinity for producing the antibodies directed against your joints. There are various phases of progression in RA. You have the initiation phase, which is sort of a non-specific inflammatory phase. So that would be early on in the disease. So the immune cells that are directed against the joints have been triggered in this phase. It's the amplification phase that comes next, and that's usually where T cells have been activated at this point. Rheumatoid arthritis has an awful lot of T cell destruction involved with it, and that occurs in the amplification phase. And then the chronic inflammatory phase, this is the worst part, the unfortunate part. This is where there are so many tissues injured. Now, as the tissue gets attacked by the T cells, these are normal tissues, they're under attack. They don't know that it's their own self attacking them, right? So they send out the normal inflammatory signs to call in help to stop the attack, which happens to be your own self, which then not only responds to the attack, but also amplifies the attack itself, right? It's going to amplify that T cell response, which of course is inappropriate. And the cytokines involved in this include interleukin-1, TNF-alpha, and interleukin-6. It is definitely an abnormal immune response. And once it's initiated, the factors that allow it to then amplify and then become chronic, those are starting to be more clearly understood with research. And they're starting to direct some of their treatments against those things to tamp down. You may not be able to stop the initiation, but maybe we could stop the amplification. Maybe we could stop that chronic inflammatory phase. And the key thing is to get in and see a rheumatologist as early as possible. Now, RF, which is the antibody, or it's called rheumatoid factor, that is found in rheumatoid arthritis, unfortunately is not, while it's found in rheumatoid arthritis, it is not unique to rheumatoid arthritis. It is found in other illnesses like Sjögren's. It's also found in non-autoimmune. You can find it in hepatitis C. You can find it in SLE. You might find it in lupus. You can also find it in some chronic infections. And unfortunately, about 10% of the healthy population will also have circulating rheumatoid factor in their blood. So while rheumatoid factor is our primary test that we do in testing for RA, it's not going to be the end. You have to do several other tests in order to back up your RA. So RF or rheumatoid factor is your first test that you're gonna do. If that's negative, you can probably stop. Okay, and you can now it's not 100%. It's not found in 100% of the RA cases, but it is highly suggestive. So then the next test that you would go to are called the anti-citrullonated protein antibodies, or ACPAs. These tests while they're not found in all cases of RA, they're only found in about 67% of RA cases, but they're rarely positive if RA is not present. So very rarely found in the healthy population, the non-RA population, I should say. So while you get about 2/3, right, of the population who has RA would then cause a positive ACPA. However, by using the RF and the ACPA together, it helps you to find your rheumatoid arthritis patients more clearly. Okay. Now, ACPAs, that's actually a group of tests. There are a couple of different ones that you should know. There's the anti-CCP, which is a cyclic citrullonated peptide. And then there's an anti-MCV assay. These are antibodies against mutated citrullonated peptides, or citrullonated vimentin is actually the peptide that you're talking about. So those are the two that are included in the ACA, okay? And those are so you would be testing for all of those together. There are some factors that seem to increase the risk of RA. Smoking actually is one of them. There seems to be a 50% increase in the risk of RA if you smoke. However, on the bright side, moderate use of alcohol seems preventative. So there you go. Put down the ciggy, have a drink. Mycoplasma infection, unfortunately, is associated with an increased risk of arthritis. If you have had one in the past, or if you get one in the future, you have an increased risk. Rubella infection, CMV, EBV, and parvovirus. Those viruses well, they're not. Those are all associated with a higher risk of rheumatoid arthritis. The lab findings for RA, you kind of have to use both the clinical and the laboratory findings, again, to get a good diagnosis of RA. It's not one of the, it's kind of like, it's a little bit easier than SLE, but it's still somewhat difficult, okay? Usually, the patient is going to go to the doctor with joint pain. That's going to be what they're going to find. And one of the things that we should find, usually it's found with, pardon me, with imaging tests, is something called a PANIS. Pardon me. A PANIS is shown over here in this little cartoon. It's showing kind of what's going on. Tolerance is lost, and the antibodies are produced, right, by the B cell against the lining of the joint. This can be any joint, okay? As the joints become infiltrated with that autoantibody, they eventually lead to the triggering of T cells. The T cells are then going to attract more white cells, including macrophages and neutrophils, into the joint. So you're getting this swelling with all these cells in it, okay? That's going to include, the rest of the triggering is going to include things like complement activation and mast cells, macrophages, all kinds of things showing up into the cell. And what are they doing? They're responding to the presence of that antibody. Unfortunately, what is the antibody attached to? It's attached to the lining of the joint, which is your own. These cells don't really see it that way, and they start to destroy, right, attack the lining of that joint. And so you end up with this, what's called the PANIS formation. This structure that forms on the where the attack is going on, kind of on the outside edge of the cell. It has the swelling, okay, and an enlargement of the outside part of the cell, okay. It's actually a separate structure. All it is really just a clump, a giant aggregation of white cells in the area, okay. If we were to look, do some blood testing, we would see in general increased levels of acute phase reactants, and that would include things like ferritin, okay, or your CRP, your C-reactive protein would be increased. Your ESR would be increased, okay. We know how helpful the ESR is, but we got to put it in there. The ESR would be increased, okay. Now, what are the purposes of these? Well, we know what the CRP is there to do. It actually is there to bind specifically to lysophosphatidylcholine, which is that's expressed on the surface of dead or dying cells. So we know that that is supposed to be there in an acute phase reactant. And so when your CRP is increased, that means you're increasing your complement activation, right? Because CRP can activate complement via the C1q complex. Ferritin is there because it's meant to bind iron and convert it. Iron is going to be released as inflammation occurs, and so we need to have ferritin there to convert it to the non-toxic form, which is free in the serum, right? We don't want to unnecessarily, which is ironic in this area, damage tissues, even though that's what we're doing in the process here. So as during inflammation, it will be upregulated as part of your inflammatory response to the antigens. So you'll in the lab we'll actually see that increase because it's upregulated. Okay. That's what we're going to see in the serum. If we look in the synovial fluid and we look for some of these pro-inflammatory cytokines, we'll find things like interleukin 1, 6, 8, 15, 18, and we'll also find TNF alpha. Okay. We'll see some increase in enzymes in the synovial fluid. We'll see collagenase increased and other tissue degrading enzymes that are released as part of the inflammatory response, but unfortunately they result in the destruction of the connective tissues as well as the cartilage and the bone. None of it's good, right? So those are some of the things that we're seeing that are going on in the patient. But what are our tests? What tests is the doctor going to order in order to verify this diagnosis? Well, the first thing they're going to do, as we said, is the RF. You're going to do the rheumatoid factor, which again, that's present in about 75% of your RA patients. And it is, what is rheumatoid factor? It's circulating antibody, IgM, that is directed against IgG, okay? It's directed against the FC portion of the IgG. Now remember, it's not specific. We can find this actually present in about 5% of healthy patients, perfectly healthy patients. And if we get older, we can find it in 10 to 20% of those healthy, but over the age of 65. Okay. What happens is the IgM binds to the FC portion of the IgG, forming an immune complex. Unfortunately, that's going to deposit in the joints, which will essentially trigger a type 3 hypersensitivity response. Okay, remember it's IgM, very, very good at triggering complement. Okay, so complement gets triggered and cells get destroyed. However, there are some other antibodies that we can look for. These are citrulline antibodies. Remember we talked about the other two, the CV and the other two antibodies that we just talked about. There are some more citrulline antibodies that we can talk about, and that's anti-keratin, anti-perinuclear, antifilaggrin, and anti-SA. Okay, these are all just specific citrullonated proteins, which is they're generated by the modification of any protein, of a protein bound arginine by this enzyme peptidylarginine deaminase. The citrullonated proteins, why do we develop these antibodies against them? Well, citrullonated proteins are released when the granulocytes and the macrophages die at the site of inflammation. So when you have this chronic inflammation there, you have multiple granulocytes and macrophages dying inside this pannus. Part of the immune response will be directed against those antibodies, those antigens, which aren't normally released. They're not normally seen by the immune system. So they're self-antigens, but they're usually sequestered. You wouldn't normally see them. In this case, there's so many released that you develop an antibody response against them. Here's just a cartoon of the rheumatoid factor. Here's your IgM factor directed against the IgG, the FC region. Okay, not specific, but it is a pretty quick and easy test. It's a latex bead test. We do it. It's actually, we can easily automate this if so choose, but it literally takes 3 minutes to do in the laboratory. Okay, so we have a couple of different types here. These are just two different manufacturers. Okay, so one manufacturer has added color in order to help, I guess, to help watch it, to help see it better. This is the one that I'm used to. It's just the routine one. You've seen it before. It's a regular latex test, a white latex bead against a black background. You get positive, low positive, high positive, low positive, and negative. And if you add color with the other these other manufacturers, the color may help you visualize it better. We don't just report a positive or negative. Rheumatoid factor is reported as a function of a titer. So you perform a titer, a regular doubling dilution titer, and but then you convert the titer into international units. So you make sure that, because you have to have a titer control in order to run a titer control, make sure you're doing it right. Basically, if you convert it, it's really not that difficult. You just take whatever the titer number is. If it's 40, then it's 40 international units. If it's 1/40, it's 40 international units. So it's basically your dilution factor becomes your international units. Then we have thyroid diseases. Autoimmune thyroid diseases are another major problem that has developed sort of, I would say, with as we stay healthier longer, our immune system has not a lot to do, so it finds other things to do that it shouldn't be doing, is kind of the way I think of it. There is a genetic predisposition to having thyroid disease. Again, it's associated with certain HLA antigens, okay? So for example, Graves' disease has a very strong association to HLA-DR3, and Graves and Hashimoto's, the HLA DR antigens expressed on the surface of the thyroid epithelial cells get increased, and so they think that they increase the immune response against them. So you have two basic autoimmune thyroid diseases, Hashimoto's and Graves' disease. Hashimoto's is also called chronic autoimmune thyroiditis, okay? But essentially, with Hashimoto's, you have hypothyroidism, and with Graves, you have hyperthyroidism, okay? That's just a gross generalization, okay? So if we start with Hashimoto's, this generally, again, more often affects women, mostly middle-aged women. are who gets diagnosed with it. So that's the age of diagnosis. Although the median age is actually 60. So I don't know what middle-aged means to these people. And women are 5 to 10 times more likely to develop Hashimoto's. One of the earliest signs is a goiter. If you saw Seinfeld, and you know what goiter is, it's an enlarged thyroid. However, these days, our thyroids get checked fairly regularly, and so goiter is discovered often when it's very small and it's not visible to your neighbors, okay? Although actually my aunt was diagnosed in an elevator. My aunt is short and she was looking up, talking to somebody else, and there was a doctor next to her who saw the goiter protruding from her neck, and so she was diagnosed that way. Isn't that lovely? But anyway, so your thyroid changes its consistency when it's under attack, not surprisingly. And so the doctor, if you've had this test before, the doctor feels down your throat and presses in uncomfortably in order to feel your thyroid. And they can feel irregular shapes and a rubbery consistency, which is consistent with destruction of thyroid tissue. And generally what we'll find if we test your blood in those situations is we'll find hypothyroidism. So your thyroid, because it's under attack, it's not doing what it's supposed to do, and so it's not producing thyroxine, okay? And what do we find immunologically? So while the disease then becomes about your thyroid, it's actually an immunological disease, okay? The problem is it is interfering with that organ, your thyroid, which then controls the metabolism of the rest of your body. So you can see where this could be a problem. So if we test your blood, we see that you have antithyroid or thyroid autoantibodies or antithyroglobulin molecules there, okay? If you see this lovely picture here for this woman, I'm not sure if this is the top or the bottom of her modeling career, but the hypothyroidism over here, you can see the changes that go on in your body, and to any, there could be extreme or slight, mild. Okay, so any level here. Dry, coarse hair, loss of eyebrow hair, puff. Your hair actually falls out everywhere. Puffy face, enlarged thyroid, slow heartbeat, and you can see all these other things you guys all can read. Okay, these are all the symptoms that the patient might have from hypothyroidism. Okay. What they actually have going on that's causing this is, well, wait, let me go a little bit slower. What's causing this is a reduction in thyroid function because of antibodies against thyroglobulin in your blood. So as you produce the thyroxine, your antibodies attach to it and it's unable to function. Okay, as it's produced, it's attached literally at the site on the thyroid, and the attack occurs right there. So you keep destroying the thyroglobulin that is producing, the cells that are producing the thyroglobulin, and you end up with the hypothyroid symptoms. Graves' disease is kind of the opposite, a little bit, of Hashimoto's, in that, and it's actually the more common of the two. Graves' disease is the most common cause of hyperthyroidism, but it still only affects less than 1% of the population. Now, out of all of the autoimmune diseases in the US, Graves is the most prominent, but it's still less than 1%, okay? So got to know what it is and what it looks like. Women are, again, 10 times more likely to have the disease than men, okay? And what is going on with Graves' disease is you have actually thyrotoxicosis, which is a diffusely enlarged goiter or thyroid that is soft instead of rubbery. So we have two different consistencies. The Hashimoto's has a rubbery consistency, whereas the Graves has a soft consistency, like a spongy consistency. And the clinical symptoms are different. Some of them are the same. You can see there can be hair loss and hyperthyroid as well. However, it's the nervousness and the jitteriness and the insomnia and the depression, that all, and weight loss instead of weight gain. So you have some that are on the opposite end of the spectrum. The heart issues are definitely probably the most things that you're most concerned about. In hypo, you have arrhythmias. In hyper, you have palpitations. In 35% of the cases of Graves' disease, you have what's called exophthalmos. See if I can say that right. It's hypertrophy of the eye. What happens is you develop increased connective tissue in the orbit of the eyeball that causes the eyeball to bulge out. So that's, while it's not in most of the cases, only in about a third of the cases, it's very characteristic of Graves' disease. The major antibody with Graves' disease is a thyroid stimulating hormone receptor antibody, or TSHR-AB. Okay, so it's the anti-thyroid stimulating hormone receptor, or TSH receptor. Okay, and the other one that they also produce are antibodies against thyroid peroxidase. So when you have the antigen antibody binding complex, right? So the antibody is binding to the thyroid receptor. That's actually going to mimic the normal action of TSH. So it seems like you're calling for increased metabolism when it's actually an immune response against that receptor. So that's where the symptoms of that hyperthyroid come from. The lab testing that you're going to get, there are three major antibodies that are involved with thyroid autoimmune, and those are the antithyroglobulin of Hashimoto's, the thyroid peroxidase, and the TSH receptors. 90% of patients have an antithyroglobulin. They demonstrate antithyroglobulin. And these are usually found using passive hemagglutination. So you can actually use tanned red blood cells, or they're chemically activated red blood cells that are allowed to interact with the patient's serum. And you can actually see hemagglutination of these patients, of these red cells. But there's also an indirect immunofluorescent test. It's a little less sensitive, but you can detect any of the antibodies that aren't able to agglutinate. Okay, so free and agglutinated ones. But at these days, actually, we use EIA. That's what we're using these days. It's easier and it's automated. Okay. The antithyroid peroxidase, or anti-TPO, the peroxidase, what it's there for, the thyroid peroxidase, normally that's there in order to catalyze tyrosine iodinization, right? Add the iodine. So the thyroid peroxidase, or anti-peroxidase, that correlates with disease activity. The higher your anti-TPO level is, the more active your disease is. Again, these are diseases that go through fits and starts. 90% of patients with Hashimoto's will have TPO, antithyroid peroxidase, and 80% of Graves patients. So that one is common to both diseases. And again, most commonly measured by EIA. But there are other methods you can use. Immunofluorescent assays, you can use particle agglutination studies. You know, the reality is EIA is the easiest to use these days. And then finally, we have the anti-TSHR, thyroid stimulating hormone receptor. This one's associated with Graves' disease. This test is actually more difficult and it's more expensive. So generally, we usually don't do this test directly. Um, we usually do the diagnosis through noting the elevation of thyroid hormones, whether it's T3, T4, and you also look for a lowered TSH. That's usually how they diagnose Graves. If it needs to be done, the anti-TSHR can be done via a bioassay and binding assays. So that would require a tissue culture, so because you need the receptor to be present, right? So you use a tissue culture and you do binding assays where you have competition between radio-labeled TSH and patient autoantibodies. It's not the most sensitive a method, but it's the method that we have out there at the moment. There have been found other versions of thyroid stimulating hormone receptor found in Hashimoto's, but it's not against the same epitope, and so you don't get the same effects, right? So it doesn't stimulate the release of thyroxine. The other key things and the ones that are used to monitor these patients are the T3 and the T4. So these are the products, right, that we get of the thyroid. And so looking at the results that we would have in a patient with uncontrolled Graves, their thyroid receptor, I'm sorry, thyroid receptor, their thyroxine is down, their TSH is down, and their T3 and their T4 are up. In Hashimoto's, thyroxine is up, TSH is up, and your T3 and your T4 are down. Okay, so you see you can have opposite results for these. Then we have diabetes mellitus. This is also type 1 diabetes mellitus, can be the result of an autoimmune disorder. There are different causes to the loss of, you might be born without them. But essentially, they're showing that much of diabetes can actually, that we find today, can be found as a result of chronic autoimmune disease in genetically susceptible patients. Okay, they think it's probably the result of environmental factors, but basically you end up with the selective destruction of beta cells of the pancreas, which, if you remember, are found in the islets of Langerhans. Now, in thyroid, if you lose your thyroid, we can actually take out your whole thyroid and end the whole immune problem, right? You wouldn't have the immune problem. We would be able to replace the hormones that you're missing from that organ. But unlike that, in this case, you can't just easily replace insulin orally today. They're starting to get there, but because insulin would be destroyed, because insulin is a protein, it would be destroyed in the stomach. And pardon me. And while they're working on protecting it from the stomach, it's still not 100%. So insulin is still primarily given as a shot. Okay. Pardon me. So what you end up with then is this situation where progressive inflammation of those islets of Langerhans leads to fibrosis and the destruction of most of your beta cells. There can also be immunity or autoimmunity to the insulin itself. So you can have a couple of things going on at the same time. Okay, so there actually are several autoantibodies possible here, and those are all based on what we have found. This is what's going on. This is the beta cell. Okay, it's a cartoon, obviously, but this is the beta cell, and we have found antibodies directed against not just the whole beta cell, but to the different components of it. You have, pardon me, the let's see. Insulinoma antigen 2 or IA2, insulinoma antigen 2B, 2 beta A, they have a whole bunch. The anti-insulin, the anti-GAD or glutamate decarboxylase. There are several other ones, other islet cell antibodies, the ICAs, okay? So there are actually a lot of things that can be going on that can be targeted at one or more of them. What frequently happens is you develop you develop an antibody against one, and the immune response against that triggers the antibodies to form against the others. It's a vicious cycle. The lab testing for diabetes is still done mostly by identifying hyperglycemia. Okay, now there's a lot more work being done to identify pre-diabetes, but that's still done using glucose levels. Okay, testing for those specific antibodies is not routinely done at this point. It is possible, and you can see here, this is islet cell autoantibodies demonstrated using green fluorescence. So this is a section of the human pancreas. It's not yours, obviously. So this is a donated section of human pancreas on, a slide, and then we let our patient's serum interact with this, and if they have antibodies, they'll bind, and then you end up you do your conjugate, and so you end up being able to test for this. This is still not the common way to do it. It is possible, but I don't think even insurance companies are paying for it yet. They're just using the pre-diabetes screening. Okay. If we could get them to pay for it, we could probably find people who are developing these autoimmune diseases a lot sooner, because you'll have this inflammation for ages before you actually develop the overt symptoms. Now, how many other autoimmune diseases are there? Let me count the ways. There are so many more. However, we're not going to have, go crazy on all of them. So in this case, what I'm giving you is the disease, okay, the organ or the tissue that's affected, and then what is the immunologically, what is the issue? So you can see as you go across Addison's disease, the immune response is directed against the adrenal glands because you actually have an antibody against adrenal cells. And if you go down the list, let me get my thing. So sojourns, I've mentioned sojourns a number of times, right? Sojourns, actually the two most common tissues that are affected are the eyes and the mouth. You have several antibodies here, but they seem to be directed locally against the eyes and the mouth. And the key things there are anti-salivary and anti-lacrimal antibodies. Okay. Sarcoidosis. You have multisystems. You have granulomas found throughout the patient. This is actually a pretty severe situation. This is actually T-cell led. So it is an immune issue, but it is a function of T-cell activation. Okay, you've heard of some of these other ones before. Obviously, you know what hemolytic anemia is. Crohn's disease, they found inflammatory infiltrate T and B cells, although the mechanism is unknown in the intestines. They're still working on this one. Disseminated encephalomyelitis, sensitized T cells present in the brain, not good. Okay. Pernicious anemia, we have an antibody directed against parietal cell and an intrinsic factor antibody, not good. Okay, so you can see, read through this, and this is what I want you to know about it. And then finally, we put this in here. It is an autoimmune disease, but it's kind of like on a different level than all the other ones, right? Multiple sclerosis. So we know that there is an autoimmune disease, an autoimmune disorder going on, and that it's an inflammatory response. But we kind of chase multiple sclerosis. We're not really sure exactly what's going on. Some of the hypotheses is that molecular mimicry might be behind the immune breakdown. There are some viral triggers that might be the problem, that if they are presented on HLA, they might trigger T cells. EBV has been implicated with multiple sclerosis. There are 4 times more antibodies to EBV in MS patients than in other patients. But there are other viruses that have also been implicated a lot. They've looked into measles and herpes simplex and varicella. Varicella is a CNS virus, right? So is herpes. Influenza, there are a ton. They've just looked into so many. What do we see? Well, if we have imaging studies, we can see plaques, we can see lesions in the white matter, okay, which we know is caused by a destruction of the myelin sheath. Again, how did that start? We don't know where the breakdown was. That's the part. Not quite sure where the breakdown was. Now, depending on where those lesions are, the symptoms can be pretty wide-ranging. Some of the things that that patients might experience include visual disturbances, weakness, or diminished dexterity in one or more limbs. They might have incoordination, right? Inability to walk smoothly, dizziness, facial palsy, sensory abnormalities, pins and needles, stuff like that. All of these things, and it could be wide-ranging, mild to severe. Okay, again, it's autoimmune, so fits and starts. You try and keep it in remission, but since it's hard to know what caused it, it's hard to keep it in remission. But what's occurring is you have anti-myelin basic protein antibodies. So antibodies are binding to the myelin, creating an immune response against the myelin, against inside the brain. So you have macrophages, which are basically macrophages of the brain, and microglial cells. Again, those are they're sort of like the dendritic cells of the brain, and they're attacking what they are being told is an offending agent. It's not, it's your brain. Okay. So your nervous tissue being incredibly sensitive to this, you get acute inflammation and injury to both the axons and the glia, which is followed by repair. So you can get some recovery of function, but then there is a stage of post-inflammatory neurodegeneration where it's been described to me as, so your brain has to decide what's important. After this attack has occurred, your brain has to decide what to let go of. Okay, I'm gonna, prioritize this over that. And it doesn't ask you. Okay. Now the T cells, you don't normally have a whole bunch of T cells in your brain, right? They had to be able to penetrate the blood-brain barrier in order to initiate that immune response, which means that there had to be some kind of endothelial changes in the blood-brain barrier to allow those T cells through. But there doesn't seem to be any change in it that we can detect otherwise. So some of the hypotheses include special receptors for T cell movement through the blood-brain barrier that might include a genetic component. We don't know. Now, the most common test that we have for multiple sclerosis that we use is actually oligoclonal banding. This is it's oligoclonal banding and a CSF IgG index. We use those two together. The immunoglobulin is increased in the spinal fluid between in 75 to 90% of MS patients. And that will result in very distinct bands that are not seen in the serum. So meaning the antibodies are there, but they're in the CSF, right? They're produced and released in the CSF. So if you do oligoclonal banding, you compare the Ig bands, the immunoglobulin bands found in the serum to the ones found in the CSF. And there's a particular area, usually at the base here, where you would find extra bands. And you can see those bands here in this patient, but there are no extra bands here. Don't look up here, that's not where you would find them. They're found in a particular area, okay? So oligoclonal bands are absent here, but you can see them here on this side. So the presence of oligoclonal bands is, depending on how many you see, is highly suggestive of MS. They have found up to 8 bands present. You need to see at least 4 in order to call it positive, okay? Or they actually report it as oligoclonal bands present, okay? And then you also do a CSF Ig index, which is basically a ratio. You compare the spinal fluid levels of Ig to serum levels. So that gives you the overall increase that you would see there. Now, there is not any one antibody that is perfectly diagnostic for MS, but there are antibodies that are commonly found. You have, of course, your anti-myelin basic protein, anti-MBP. You also have antibodies directed against various components of the oligodendrocytes and against myelin membranes. So there are several of them that could be present. Those are usually done as serum tests, okay? The oligoclonal bands that you receive for CSF, you have to get a CSF, obviously, but you also need a plasma that is collected at the same time, so that you can't use an old one, right? That you have to have them collected at the same time, and those have to be sent out at the same time. The lab won't do them, okay? Now, the comparison for the immunoglobulin indexes, normally your serum levels for the normal adult are somewhere between 750 and 1600 milligrams per deciliter. That's fairly normal. But your CSF Ig levels are usually pretty low. They're usually between 0 is not uncommon to about 8 milligrams per deciliter. Okay, so that leaves your normal IgG index, that ratio, anywhere between 0 and 0.85. Okay, that's normal. In a MS patient, in about 80% of MS patients, that IgG index will be elevated. Okay, and so that's why we perform that. Then we have another autoimmune disease called myasthenia gravis. This is actually, again, rare, but it is devastating, unfortunately, to the patient. This is an autoimmune disease that affects the neuromuscular junction. It is characterized by weakness and fatigability of skeletal muscles. So your muscles just wear out really fast, okay? And this would be when you're affected when you're young. Okay, this isn't like normal aging. Okay, what you have here is you have antibody that is directed against acetylcholine receptors that is causing an immune response against the neuromuscular junction, leading to destruction of those receptors. Okay. And that leads to, if you don't have the receptors, you're not going to have any triggering of the muscle. So the muscle gets, I wouldn't say, the muscle itself is not necessarily damaged as much as it is disused. Okay. and so you get progressive muscle weakness. The early signs of this, usually the first muscles that they see are in the face. So you start to see things like drooping eyelids, and the corners of the mouth droop. So you're unable to retract the corners of your mouth. And this will affect your ability to speak, to chew, to swallow, unfortunately. And it progresses, it can progress at any speed really, but it progresses to the rest of the body, to the point where you're unable to support, your chest, your trunk, your head, your neck. And it may unfortunately affect the respiratory muscles, which obviously can lead to respiratory arrest. Myasthenia gravis is most often seen in conjunction with other autoimmune diseases. So whether it's SLE or RA, or pernicious anemia, whatever the autoimmune disease is, it's most often associated with some other disease. And 80 to 85% of MG patients have an antibody to that acetylcholine receptor. And that usually is the main contributor to the pathogenesis. However, the other antibody that also might be present is an anti-muscle specific kinase. And then we have good pasture syndrome. And this, of course, you've heard of before. This is a kidney and lung issue where the patient has an autoantibody against glomerular, renal tubular, and alveolar basement membrane antigens. Okay, so it results in damage primarily. It's most frequently seen in the kidneys, so it's associated with renal damage, but 50 to 70% may also show pulmonary hemorrhage, which results from the inflammatory response against the alveolar basement membrane. It's just that the renal failure seems to be a little bit more common. This one's unique among autoimmune disorders in that it is actually more commonly found in men, usually men between the ages of 18 to 35. And it is often a secondary to a viral infection. The issue with this is a very high mortality rate. The mortality rate is as high as 50% with this particular disease. The renal failure can be crashing, so it can happen so quickly that there's not much you can do. And if I produce an antibody against the basement membrane of this kidney, I'm going to produce it against my other kidney as well, so I get bilateral kidney failure. That's difficult to overcome.